and to make improvements. Now let's begin our program. It's my pleasure to introduce Amanda Chawla. Amanda is Vice President of Supply Chain at Stanford Health Care. She has over 15 years as an influential leader across supply chain and in executive leadership at various healthcare organizations, including a level 1 trauma hospital, academic medical center, community hospital, and private practice. Amanda is responsible for over $1 billion of non-labor spend across the enterprise, and she has successfully saved over $150 million in expense reduction through various cost reduction strategies. Amanda, I want to thank you for supporting SMI and for presenting this webinar today. And with that, I'll turn things over to you. Amanda, welcome.
Great. Thank you so much, Christine. Good morning or good afternoon, everyone. I'm excited to share our story of innovating supply chain at Stanford. I want to thank you for taking the time and hope that you will find this session to be valuable, whether you are a supplier or provider. So, again, thank you so much for joining. I want to start off with sharing the Stanford story. Stanford University was founded in 1885 by Leland and Jane Stanford. Leland and Jane Stanford had a son by the name of Leland Jr. Leland Jr., while traveling with his family from Italy, got typhoid and unfortunately passed away at the age of 15 or 16. It was so devastating for the Stanford family that they decided that they wanted to build an Ivy University on the West Coast to promote the public welfare, the exercising influence on behalf of humanity and civilization. And so they started Stanford University, which is the co-ed school and was free when it first started. Not so much anymore. Stanford Medicine today is made up of multiple legal entities. It's made up of Stanford Health Care, which is an adult hospital. It's made up of Lucille Packard Children's Hospital. It's made up of Valley Care, which is a community hospital. And it's made up of RPCHA and UHA physician practices. So a multitude of legally separate entities with multiple hospital boards reporting into Stanford Medicine. Stanford Supply Chain at a glance is Stanford Supply Chain is a shared service amongst the multiple hospitals and entities in which we're providing services to 1,200 plus licensed breads, 106 ORs, and touching 2.5 million plus outpatient encounters a year. Some fun facts to just share in terms of the level of touch that Stanford Supply Chain has is we physically touch and manage over 1,000 plus PAR locations on a daily basis, $1 billion plus in spend, and really 31.5 million items. So just giving you a breadth and a depth of the organization. Stanford culturally is very much an organization that's around innovation, leading cutting edge medicine, and it really is a learning organization. And you can see, Stanford first developed a linear accelerator for cancer radiation treatment. We developed the CyberKnife, very, very heavy on the clinical side. Clinical innovation has been part of our core DNA at Stanford. And now as we transition and start really looking at the supply chain side of the house, supply chain was quite the opposite and has been quite the opposite. So really started off with how do we meet the needs of a value-based healthcare and rethink of supply chain to evolve closer in line with our clinical evolution. So with that, we have the traditional supply chain services of providing sourcing, category management, to inventory, bedside management, your traditional services. I joined Stanford a little over 2 years ago into this role, and when I joined, the current state of Stanford supply chain was daily escalation, out of critical supplies, low morale. Physicians really weren't aware of supply chain. Being an academic medical center with a high volume of residents and the complexity of multiple organizations, there wasn't a whole lot of coordination, if any at all. There were significant leadership gaps, and I would say there was multiple supply chains within supply chains. The cost of where Stanford was heading it was truly unsustainable. We bent that curve quite a bit, and I'll talk a little bit about that in terms of the how. And at the same time, the organization was growing and expanding in size, whether it was physical growth or patient volume growth. And again, going back to the core DNA of Stanford, is really the technology and the innovation, very strong on the clinical side, but completely absent in supply chain. So as we transition, when I joined, my mind was going in a dozen different directions, as you would going into a new leadership role in an organization, trying to assess. And so the journey to transform needed to occur in a systematic manner to speed up the process of change and change management. And that's what we're going to talk about, is really what that journey entailed and the infrastructure of that journey. So whether you are sitting here in a current organization, you've been there and you want to do change management and evolution, a way to think about that, whether you're a supplier or a provider. So what the journey began with is essentially this model. This is the blueprint that was designed and rethinking about the supply chain. So starting off with really the strategy, what's really the vision? Where do we want supply chain to be? What is it that we want to become, not where we are today? And then what's the path to get there? What's our infrastructure? How are we designed? How do we operate? Is the structure that we have make sense? What's the infrastructure required to support that strategy? The third element is leadership, looking at the leadership design, the people, the talent, the development, and retention or attraction elements. And then really diving into, organizationally, what are our processes? Do the processes we have develop that reliability in the work that's performed? And then a huge component of my role in leadership is culture and change management. Striving to go to become that innovative supply chain, how do we fundamentally change the culture of our staff, our employees, our business partners, our collaborators within Stanford and outside of Stanford? And the last component is really, what are the tools needed to do the building blocks? And that's where the technology piece comes in. So it's about how do we look at our organization and truly transform. And so this model is what we're going to go through in terms of how we've evolved in these areas and how you as an organization can take some of the Stanford learnings and perhaps apply it there. The next is another visual of where supply chain has been. So what I'm talking about today is really transforming a reactive supply chain to a highly reliability with three core elements: culture, process, and automation. And so when we started, we were probably down here on the bottom left-hand side of fragmented processes, lack of data integrity, and really want to go towards that intelligence aspect of supply chain. In the past 2 years, I would say we've gone from not even being on the chart to somewhere between transformative towards value-driven. We're still on a journey to get to that highly reliable and that technology-based and that intelligence-driven supply chain. So as I said, going back to the circle, starting off with our journey, we needed to start with our strategy. And so this slide that you're looking at is really Stanford Medicine's integrated strategic plan. Given that we're multiple entities, the entities came together and really said, what is it that brings the Stanford Medicine umbrella together? And we determined that there's three core pillars: value-focused, digitally driven, and uniquely Stanford. And within supply chain, it's how do I take the organization's highest strategy at the highest level and understand the application and bring it down, So value-focused for us in supply chain is really that efficiency and that effectiveness in the work that we do, that quality component, that clinically integrated, and we'll get into what clinically integrated looks like. Digitally driven is really how do we look at the current technology, the innovation of technology, and remove the hunting and gathering out of supply chain. We're very good firefighters. We're very good at firefighting and problem solving, but how do we take that hunting and gathering and that manual work out to bring greater reliability in our operations, and visibility upstream and downstream. And then the last component for Stanford specifically is taking uniquely Stanford and saying, how do we redefine and manage the supply chain in meeting the evolving needs of Stanford medicine in the future? And so with that, we took this and we did an exercise with our leadership team, and we said, who do we know we want to be? What do we want people to believe about our supply chain? And what do we need to be able to do and perform and act to be able to get to the supply chain vision? As a result of the strategic plan, enterprise-driven, going into a leadership exercise that we did, we then developed the supply chain vision. And we said, the supply chain vision is going to be based on our value equation. The value equation is something that we use across the hospitals around quality, service, cost, and our employees are stakeholders, you could say, and said, how do we take the value equation and build that into our Stanford vision? So we've developed our Stanford vision, and ultimately to be that top healthcare end-to-end supply chain organization where the clinical excellence meets the supply chain excellence. When we developed the vision, one of the things that we needed to do is we wanted to start with our staff, we wanted them to become evangelical about the Stanford supply chain brand. And so how do we have to create that? Again, it was really about the engagement of the exercise and the process of building the vision. And then what we developed is really an internal branding campaign of really on all of our communications that were written and verbal, whether it was basic frontline staff huddles, communication to executive presentations, we centralized on all of our communications, our tagline, in our mission graphics, so that way, whenever you think about supply chain as a vision or as a strategy, it's all interconnected. This also resulted in a multi-year roadmap. And so now that we've got our strategy and vision, I think it's important to understand what does clinically integrated mean? How do we take these fancy words of a vision and we've done the branding and we now apply it? And this is where we designed the clinically integrated supply chain model at Stanford. And so with that, there's different ways, or there's a couple of different ways of looking at clinically integrated. With ARM, the CQO movement, it's that interdisciplinary partnership to deliver care with the highest value, quality care, best outcomes, minimal waste, through the assimilation and coordination of clinical supply chain knowledge, data, and leadership, all coming together across the continuum in a safe, timely, evidence-based, and efficient manner. Or whether you look at how the American Medical Association defines clinical integration, their definition of clinical integration is the means to facilitate the coordination of patient care across conditions, providers, settings, and time in order to achieve care that is safe, timely, effective, efficient, equitable. So whichever way that you're looking at clinically integrated, for Stanford supply chain, what that really means is how do we have that united partnership and that collaboration with our providers, clinicians, operators, administrators, business partners all across the board? How do we understand where we are today in terms of opportunities, goals, and priorities, and really the chain? And so I would say we started off with what would be a very tactical supply chain that's very transactional based. With this transactional based, you'll see that we've got the sourcing perspective, logistics perspective, and we've tried to put in a supplier perspective of what a clinically integrated model looks like at the tactical. At the tactical phase of clinically integrated, you really just have the basics of a value analysis structure. You might be doing some basic benchmarking. You may have solid inventory transactions, and from a supplier standpoint, the supply chain contracts. But really, you're operating your business on a very transactional item, SKU, product basis, and not even connecting OPEX and capital and so forth. So how do we move from that tactical to that next level, which is now you're creating value. Now you're bringing in together for Stanford a single integrated supply chain, and not having multiple supply chains within a supply chain or within an organization. And that's where we develop the category management function, look at variation reductions, contract compliance, doing a little bit more than your transactional perspective. And logistics, now you're really talking about turns and obsolescence and how you're interfacing with clinical users. From a supplier standpoint, you're creating value by understanding the spend across the system, across multiple product lines and services, and bringing that forward to supply chain. As we advance into more of, I would say, a partnership, on the sourcing side, our supplier relations are more mature. We're doing procedural level utilization. We're looking at the basics beyond price on supply chain. There's some strategic contracting that's being done on logistics. You're doing utilization optimization. You're narrowing the gaps between the clinical and the non-clinical world. And as a supplier, you're actively engaged with the physicians in supply chain and or the clinical partners at the table together. And it's about opportunities that go beyond cost and really around quality and outcomes. And as we get to where we'll say our goal is that full clinical integration, that's where we're looking at the clinical, financials, executive, and operational, and really outcomes-driven alignment together, where sourcing is managing, our category management is managing at the patient level disease management. So when we're looking at categories, we've got that depth of knowledge, we've got those relationships, and we're looking at the utilization. And that might not be everything, that it's probably just a portion at that patient level. And so it's about that cost across the continuum. We're doing some level of risk sharing. We're a market influencer. On the logistics side, it's demand planning, but demand planning with intelligence. And more technology-based infrastructure to take that hunting and gathering out of supply chain and having that transparency upstream and downstream towards utilization. And from a strategic and key supplier standpoint, not every supplier will be a strategic supplier. And so it's really getting into that risk-based contracting at the outcome levels. And I put percentages, and it's really up to 20% of our contracts. It's not going to be every contract. It's not going to be a huge percent, but it's going to be those that are core, that are measurable. And so when we designed this model, it was about really taking the vision and saying, how do we take the vision and execute it to become a clinically integrated supply chain? And what are the steps that we need to do within our sourcing standpoint, or with our logistics, or with our suppliers? And so, again, 2 years ago, I started off with this assessment of let's redesign. With that, we developed the future state principles, which is a clinically integrated model. With the clinically integrated model, one of the things that we did is we looked at the infrastructure of our management team and the structure of reporting responsibilities and governance. And we decided to take the clinical service line thought process and bring that into supply chain. So, for example, when you have a clinical service line leader over let's say cardiology or cardiovascular services, they have some influence of managing the pre-op, the OR, inpatient, post-op, rehab, and so forth. It's looking across the continuum. So how do we create our supply chain to have those types of dyadic partners and models within our logistics and sourcing side? And I'll go into what that really looks like. How do we create really that singular logistics and distribution function, maximizing the resource efficiencies, that really interconnected supply chain? And so one of the first things we did is we took our supply chain and we said, you know what, our supply chain is really made up of 4 major things across the system. We've got sourcing, which consists of data governance, supplier relations, procurement, value-based selection, and then the 3 other pillars are really our logistics arms. And you'll ask, why do we have so many divisions within logistics? And that's really for that clinical integration. So you're partnering with, the C&O teams and the ancillaries, and really developing that operational leadership collaboration and that dyadic partner, not only with the physicians, but also with our clinicians. And so This is the model that we took, which resulted in what I will call our supply chain 1.0 structure. With that, again, this is just a detail of how the structure was broken out, which resulted in a change in the organizational chart of people. With that, what we also did is we said, okay, what's our infrastructure of designing material flow across the system? You know, if we're looking at value-based care, we're looking at different levels of care or different cost levels. What are the right levels of service for an inpatient OR versus a cardiac floor versus an ED versus a standalone clinic versus a physician clinic, and how do we create a model that meets that cost structure as well as that service structure? So this is a visualization of that model that we had developed and ultimately executing the hub and spoke. So a lot of what I talked about is really the infrastructure. From the infrastructure, we've built, I would say, the framework. We've designed kind of the foundation with a vision. We've put the 2x4s per se, or the infrastructure of here's how we want to operate our supply chain. Now it's really about our leadership and really looking at that recruitment, retention, and engagement standpoint. And so really identifying the right people, whether they're formal or informal leaders. And so one of the things that we do at Stanford is we utilize an employee engagement tool that provides the strength of our leaders and looking at how do we utilize the strengths of our leaders more effectively versus the areas of weaknesses. We have what we call a weekly check-in in our system where our leaders check in. And so really that frequency and touch points and being able to measure frequently of the employee engagement, whether it's your direct report leaders or your organizations. And that culture and collaboration, so engaging with our clinical stakeholders. All of this has resulted in our employee engagement being one of the highest at Stanford across all the departments, where we had 98%, and this is the last two surveys in a row, of our employees in our workforce engaging and participating in employee engagement surveys. And so it's really about how do we do this. So one way that we did this is we developed an internal communications newsletter. So this is a newsletter that's not written by management, it's written by our frontline staff, who we call change management champions. And it's something that's done monthly, in which they have an opportunity to talk about what they're doing in their department, or recognize a certain activity, or talk about a significant change. And so this is one way in which we've bridged the gaps of communication and really looked at communication as a key ingredient of leadership. Other ways in which we've done this is really looking at our partnerships. And so for our external partners, being an academic medical Stanford or academic medical center, we have Stanford University in our yard. And so we've leveraged Stanford University students and their talents to come on site and help our supply chain and help us really look at the technology side of our supply chain and how do we do analytic systems. We've held our first supplier summit, which I'm going to go into in a little bit. Then it's about how do we have the voice of the customer. And the voice of customer is really important for us to have that regular feedback. And that's the shared huddle structure that we have. That's the visibility. That's also our redesign of our category management. As I mentioned, we have introduced category managers, but we have introduced our category management model in a way that our category managers are really by the hospital defined service lines. And so what meets Stanford needs. And they sit as a clinical or an integrated member with the physicians, with the clinical operations folks, and are really interconnected from a quality and outcomes perspective, and they're bringing in the cost element. And so aligning that has been really, really important for us, and actually quite successful. The other piece is our employees. I talked about the frontline newsletter. We also do semi-annual all-hands town halls, quarterly all-hands leadership meetings from the supervisor level all the way up. And that really helps with the communication and the reinforcement of where we're heading, but also the execution of much of our path. From a physician and resident standpoint, we're doing joint grand rounds with residents, teaching our residents and our physicians at the same time of what a clinically integrated supply chain looks like, the roadmap. We redesigned our value-based selection programs. The way we've done value analysis is we've taken the model where it's no longer a supply chain-led committee. They're either physician-led or nursing-led, depending on which committee. And we have created sub-value-based selection committees that are driven by the service line. And so, for example, if we have a category manager that's responsible for the orthopedic service line, that category manager is the facilitator and the supportive arm of the cardiovascular value-based selection service line or value-based selection committee. And so it's really integrating those things while having that global oversight of the steering committee. And so it's building in that. And then the last thing that we've done is we've developed an incentive program for our physicians through the School of Medicine, in which the school gets a portion of the savings and or the program, not the individual physicians. So really strategically looking at how do we closer partner with our physicians, not only on your traditional value analysis, but outside of that. And that's where we've introduced our category managers as part of the clinical service line committees and work there. And then from an executive standpoint, it's the structure, it's the president, it's the governance model that we've created. And we have a monthly supply chain governance committee where we invite our clinical and senior operational leaders together, and we talk about, here's where we are at goals, here's what we're working on. And so that way, now we have aligned priorities and alignment on the things that we're working on. And then lastly, from a procure to pay perspective, we've really partnered with finance to create essentially a finance monthly managers forum, and it's finance and supply chain led for the organization, in which we reinforce our procure to pay policies and practices, our financials, and really taking a look at that continuing education, but at the leadership level in which we develop the partnerships. And so I think a key component to our journey and our evolution is how we've taken leadership and how we've really partnered. I would say for those of you that are on the line that are really a supplier, it's really working with supply chain and the business partners and physicians. It's understanding how the organization wants to communicate through a clinically integrated supply chain. So some organizations will have value analysis, category management, sourcing leaders, and it's following the process. It's presenting value, from a partnership standpoint. What other value can you bring when you partner with an organization, and thinking of alternatives beyond cost and price. It's following process policies and protocols. That's really easy to say, but it's amazing how many times either those are not known or those are not followed. It's communicating and understanding the product lines and developing that, I would say, that trust with the supply chain in that proactive communication of any disruptions in the supply market. It's partnering on solutions. And so ultimately, the partnership, I think, truly comes down, at least at Stanford Medicine, is really understanding our entire portfolio of business and engaging and bringing that value more forward. It's helping us lead ourselves more clearly, and it's helping organizations understand what's most important to them. And so as we move from leadership, we've talked a little bit about partnerships, whether it's internally, if you're a provider within a healthcare organization, how you may want to look at that, or whether you're a supplier. And now it's about, okay, we've talked about strategy, we've talked about infrastructure, process, leadership, and now it's, okay, what are the processes in which we bring that reliability? Stanford's culture is really around leadership standard work. We've taken Kaizen, continuous improvement, and Lean Six Sigma and develop really our own leadership standard work model. And so what that model looks like at every level of our organization is a sequence of daily activities. It's auditing, how we do our processes. It's having organizational and department structured Gembas. It's the voice of the customers. I'll dive a little bit into team huddles and visual management. And so one of the things that we fundamentally had to do is we had to rethink about our huddle structure because our communication on a daily basis starts with how do we communicate up and down vertically as well as horizontally across the organization. And what you see here is really a tier level where from our front line on a singular, every single day basis, there is direct communication up to the executive team at tier 4. And so there's a cascading of huddles. And so one of the things that we did across supply chain, because we are across multiple different locations and organizations, is we developed an electronic system in which we do electronic huddle boards. And McDonald huddle boards automatically populate the tier 1, tier 2 to tier 3 huddle infrastructure. So our metrics that are important and or our escalations or hot topics auto-populate for the next tier huddle to do their huddle structure. That's helped bring transparency, but also from a process standpoint, we fundamentally redesigned the way in which we do our business, starting off with a strong structure on a daily basis. Other things in terms of process reliability is really creating that process owners of breaking down the supply chains in which folks have vertical and horizontal responsibilities. So it's a bit matrixed. As I mentioned earlier at Stanford, we have 3 different divisions of logistics. And we're going to have one policy owner, we're going to have one process owner that essentially provides that guidance across the other logistics teams. So it's really that matrix approach. From a process standpoint, I mentioned the value-based selection program, redesigning that program and evolving that. We also we utilized IT technology for ticketing systems, and we brought that exact same technology and just deployed it within supply chain. And that has helped us with handoffs and coordinations within our supply chain and really the management of our systems. And the other thing we did is to become clinically integrated, we had to change our own language. We had to change our own way of reporting and or communicating issues. So we adopted the SBAR, we adopted A3s, and so when there is an issue or there is a problem or there is an opportunity, we're all communicating in the same language, in the same format. And so that's another thing that we've done. Now transitioning from process to really culture change management, which I think is the heart and core of the transformation journey, is really around the technology, process, and people, is that strategic alignment that we've built with our physicians, with our employees, with our executive partners, having the ability to dive deep internally within the organization and also view what's coming forward, having champions, champions not only within your own workforce, but champions across your colleagues, and then being able to communicate effectively and being that flexibility. So utilizing this model, all of our leaders, when we're talking about any implementation of any new tools, technology, systems, processes, we always come back to this and say, are we doing the cultural change effectively? And so one of the ways that we've looked at technology is from basic things of innovating the way in which we manage our day-to-day operations and our help desk tickets to how do our clinicians communicate to us that they want changes, and how do we systematically do that? So we implemented, basic Microsoft Office tools in the way that we did things. From a demand planning and forecasting, while this is still quite manual in terms of the data pulls and so forth, we've developed the standards, we've developed a push system, and we've developed drivers and metrics in which we're managing proactively. We've also, from a technology standpoint, gotten on the same platform as our nursing colleagues and our clinical colleagues. and really linking that technology to other technologies that we're utilizing in the organization, whether it's robotics or whether it's RFID. And now what we're really looking at is where do we take this technology to the next level? How do we innovate with the partners that we do have? So as a result of kind of all of this work over the past 2 years, we received a 2-page highlight in our board report about our progress. We've developed, results in terms of our trackability of requests. We've saved millions of dollars, hundreds of millions now at Stanford, and we've rethought the way in which we do business, and we've really built that Stanford relationship. And one of our key focuses, while it's been truly internal over the past 2 years, is really shifting to our partners that we rely on and our suppliers. So as a result, this has allowed for us to have some simple wins in which we look and solve problems as well as complex wins. So I want to share a story. So we had essentially a near miss in terms of a patient safety incident with MRI tanks, with the MRI with O2 tanks that were not MRI compatible. It was an isolated situation at one of our organizations in which the nurse just told the technician, the radiology technician, told a frontline staff member. That frontline staff member, from a culture standpoint, brought this forward to a leadership perspective within supply chain. Supply chain then brought the leaders of all the organizations together and said, look, we've had a safety incident. What's the possibility of rethinking the way we do things? Because we can do education on compatible tanks and non-compatible. And what it resulted in is the organization coming together with supply chain leadership, driving a higher quality of safety and reliability in the way we do our business. So it doesn't have to be, a direct cost element, but this is a simple way of demonstrating that partnership and what that clinically integrated supply chain has allowed for from our front line all the way up. While we also have complex issues, and I know, every organization works with this, but what the conversation started with is a position and initiative within one of our service lines to improve a standardized patient care roadmap. How do we standardize, not even order sites, but standardize certain protocols with residents? And so what that conversation first iterated to was we can only focus on the clinical side. The initial response when supply chain got engaged was there's really no appetite for change. We're an academic medical center. We have to have variation of medical supplies. They're required for training. They're required for optimal care. And so over the past year that we've been working on this, we've developed a relationship with our physicians by, really using a few elements. One, we're going to present you data, but it's not going to be perfect. It's going to be directional. We know we don't have perfect data, but let's look at it as an 80-20. Cost is secondary. Let's think about the value. So if you're streamlining your protocols with this service line, why can't you streamline the products and what you use with that? And really being stewards of the variation, patient health and variation reduction. What that resulted in with this one initiative is we had millions of savings and really a 30% reduction in probably pretty good pricing already across one of our service lines on all the products. So we looked at it from a complete product basket. And so while we've done a great job in terms of really evolutionizing or changing our supply chain, we still have a number of challenges. And I think these are challenges that many of you can resonate with. And really that is around, the speed and execution in which we need to do that work and the ability to sustain that change that you're trying to make. It's balancing, fixing the basics while innovating at the same time. A huge component is the constant change management. For Stanford specifically, one of the challenges we have and continue to have is we have a lot of independent technologies and systems. So while we have a lot of data, it's how are we utilizing the analytics, or what are the analytics, and the accuracy of that data, and how do we bring intelligence from there. For supply chain, it continues to be the lack of true intellect, and I'll use the word intellect, of the complete supply chain, and really ultimately finding the fine balance of quality, cost, and efficiency. The bottom line here is being dynamic and adaptive and agile, recognizing that what you may try may or may not work. And so while we're 2 years into our journey, we just passed our 2-year mark, we're now talking about the next level of evolution. And with that next level of evolution, it's rethinking our supply chain. So one of the things that will be coming forward at Stanford is really looking at that infrastructure and saying, this is what's worked well, this is where we've progressed, and these are areas that we need to continue to work on or that we have not progressed on. And does it make sense for us to rethink our supply chain? So we're now at a stage where we're moving from supply chain 1.0 to what we'll call supply chain 2.0. And this graphic is intended to design the level of change that we're going to implement as we implement our supply chain 2.0 structure, in which we fundamentally shuffle up the departments and redesign supply chain in terms of bringing the frontline operations, which is our service and delivery, together with a core of the back of the house, which is enabling and supporting the rest of our supply chain, strategy and procurement, that procure to receive, and that partnership with finance while we have a back-end support. So that's the next evolution of our change. But what I would say, the biggest thing that we come back to is going to be that change graphic. And the way that Stanford is looking at change is, disruption is an opportunity and not as a threat, and resetting the game on the business model to better leverage the technology and continuous involvement is a key component of our journey to get to that clinically integrated supply chain, that level 5 model that we've developed. So in conclusion, I would say it's really about how are we designed, how do you operate, and this is a model that you could utilize whether you're a provider or a supplier, and whether you're managing a small business or a large part of your business, and rethinking about how do you push the envelope and rethink the way in which you're doing your business, in which you're transforming and not staying stagnant. And that's all that I have today.
Great. Thank you, Amanda. That was extremely beneficial. And I just want to remind everyone that if you do have questions for Amanda, you can submit them via the questions feature on the GoToWebinar system. Amanda, we have a couple questions here. So someone would like to know how many people are on your staff and how is your supply chain team structured?
So today we have about 300 total staff members across the system. We are increasing to about closer to 350, 380 with the growth and the opening of our new hospitals. In terms of the structure conversation, let me just go back here. This has been our structure where we have sourcing all truly combined in 3 logistics operations. We're in the process of doing that supply chain 2.0 transformation, in which we will be restructuring over the next 60 days our supply chain and redesigning how these departments are reporting into kind of this model of service delivery, enable of support, source and service, and back at the end, where we're bringing in that centralization of distribution and logistics. We're going to continue to have the 3 divisions, but we're bringing out what I would say the system analytics and enterprise function as a central core, and really placing demand planning within that. And then under the procurement side, to closer partner with our controller's office, we're taking receiving out of logistics and closer partnering with purchasing, and then we'll have an office that does business transformation and operations. That's a very small group. But it is, I think, a core function of our structure.
Okay, great. Next question. How did you said in the beginning that there wasn't a lot of awareness of supply chain with physicians. How did you promote that awareness of the supply chain transformation that you brought us through today with physicians?
Yeah, sorry, there's just a little bit of background noise here in the hospital. A number of things. I think, first of all, the awareness has to start within internally your team. Your leaders have to believe in and be as strong change management and evangelical about the work that you're doing. It has to translate internally to your frontline staff. Our frontline staff touch our clinicians much more visibly than any of us in leadership in our leadership meetings. So we started there. Then what I did is I had a whole number and series of communications at our executive meetings where being a member of the multiple executive leadership teams, because we have multiple hospitals, is really talking about supply chain and really getting the buy-in at the executive meetings and having one-on-ones. So one of the things that we did strategically with our dyadic partnership is I went through the list of our organization and key leaders, and I said, I am a dyadic partner to XYZ and these roles, and I'm going to commit to touching base with them 30 minutes a month or once a quarter, depending on what the role was. And we did the same for all of our leaders. And so now that then resulted in developing relationships, and then fundamentally, sitting down with the CMO and quality office and talking about value analysis and going out to the physician road shows. And first of all, hearing and getting some small wins, and then getting them to truly own the value-based selection program resulted in the partnership propelling at a much faster speed than it normally would have. So fundamentally redesigning the way we do our work through the dyadic relationships. I think that's the core ingredient of getting that reliability and that execution.
Okay, that sounds great. The next question, are there pieces to your contracting process you have needed to revisit or revise since implementation?
To our contracting process?
Yes, yep, your contracting process.
So I would say that that's one of the areas that we still have to fundamentally work on and continue to strive. That's one of those things that didn't work as well, primarily because our focus has been on the partnership and the operations and the execution side. And so fundamentally, one of the pieces that we have redesigned is really with the category management team now designed by service line, is their relationship with the business management functions and making sure that supply chain is at the front end of the conversation and not at the back end of the contracting conversations. And so that's fundamentally what we have done well at in terms of truly doing, supplier scorecards and things of that sort. That's part of our continued journey in which we still have work to do.
Okay, then someone also wanted to know about online terms and conditions. Is that a departure from what was the previous process? What effect has that had regarding time savings in your workflow?
I'm sorry, Christine, repeat that again. Online terms and conditions?
Yep, it says regarding online terms and conditions. Is that a departure from what the previous process was, and what effect has that had regarding time savings in your workflow?
Yeah, so so we are doing some work around that. I would say that that's something that we've started recently as part of our journey and as part of our partnership with the controller's office and with our suppliers, is rethinking the way in which we do our business and the execution of that. And a good example of this is we actually had a multi-day retreat of supply chain and the controller's office and our business partners, and rethought about the way in which we do a little bit of that contracting, but about terms and conditions, and bringing in automation and removing the non-value added. But I would say we're very early on that part of the journey. But we do have plans in terms of automating some of our processes and strategically executing across multiple hospitals.
Okay. Amanda, that's all the questions that we have. I want to Remind everyone that there will be a brief survey at the conclusion of a program today. When you exit out of GoToMeeting, there'll be an evaluation survey. Please take a few moments to provide your feedback. We really do use this information to make improvements for future sessions. I'm going to give everyone a few minutes back in their hour. And Amanda, I want to thank you so much again for supporting SMI and for presenting this webinar today. We'll be sending out the slides to all of the participants, and also we'll be sending out a link to the recording. So Amanda, thank you so much, and I hope everyone has a great rest of the day.
Absolutely. Thank you for the opportunity, and thank you everyone for your valuable time.